I think he just went to sleep. I think he does that. Oh, in the theater. That was Mr. Hormones and so I have to order slides right now. Oh, okay. So you can just give me a signal. I'll just give you the thumbs up. You have to hit that. I'm not very technologically adept, I'll be honest with you. Omar?
Yes.
I went to sleep again.
Oh, did?
Yeah.
Your computer's plugged in? Did it go to sleep?
Yeah, it was on. Oh, here it goes. Okay, there you go. Yeah, I can have you come up. Around here.
Give me 1 second just to.
Okay.
Yes. Well, yeah.
It is gorgeous.
Yeah, we just look.
That's what I was wondering. And if I take that, or I get used to that, they always need to take a college.
Do you mind just coming a little more into the camera? That's.
All right, we're going to get started back up with Dr. Babos, who's going to be speaking on pain and an intersection where pharmaceuticals and botanicals meet, and she came all the way up from Tennessee, and we super appreciate it. Great.
Howdy, everybody. I'm from East Fort Payne, Tennessee, although I'm originally from Pennsylvania. I'm a transplant. So I'm here and I'm hoping to cover, not very deeply, but a broad prospectus on both pharmaceuticals and where they intersect with botanicals and pain. I am not a naturopathic physician, although I'm a wannabe, right? No, everybody is, I think. That's not my training. My training is in pharmacy. I'm an old pharmacist who started as a bachelor's degree pharmacist when I was 22 years old in 1985. I went and got my PharmD. I also have master's degrees in pharmaceutical chemistry and toxicology because my love is molecules. I'm really grateful that my mom signed me up for pharmacy school because at 17 I wanted to be an electrician. I wanted to have a job where I could wear blue jeans and steel-toed boots. That was my goal at 17, but my mom signed me up for pharmacy school and told me either you go or you're on your own. So pharmacy school it was. I thought, great, I'll learn about plants. No, my class was the first class that did not get pharmacognosy. They had eliminated it the year before I started. So for a long part of my life, I had both a full-grade teacher and a student about herbal medicine because I taught myself, until I went to the Eclectic School of Herbal Medicine in Low Gap, Virginia, and studied functional herbalism for about a year. I'm still learning, and hopefully I will continue to learn. So I drove up yesterday in the rain, and it was a lovely day for geese. And as I was driving along up Interstate 81, I saw this gaggle of Canadian geese fly overhead, and I noticed that one arm in that traditional V formation was longer than the other. And I had an epiphany, and I finally realized why. It's because there's more geese in that arm, right? So hopefully I'm here not to restate the obvious things like that. I'm not beginning as I go on. But that being said, like I said, I'm going to try to do this broad prospectus. I teach pharmacology. In a medical school, I teach pharmacology to nurse practitioner students, osteopathic medical students, and physician assistant students. So I was kind of assuming when Dr. Giordinelli asked me to come here and speak that she would want me to speak about the things that I know about the most. So that is the focus of this pharmacodynamics, where drugs for pain poke at our physiology with a little bit of my smattering of botanical knowledge, pharmacokinetics, pharmacodynamics, and where botanicals and pharmaceutics can potentially be a benefit or a harm to your patients. So that being said, here are our objectives. Relating the pharmacology of the federal legend medications used in non-cancer pain management to their physiologic effects. That's what I do for a living. I tell my students I'm a bit of a prostitute because I do something for money that I have no passion for, which is drugs. Okay? So bear with me on that. We're going to review the evidence underlying the current practice standards for the use of federal legend meds in non-cancer pain a little bit. I hate guidelines, I'll be honest. I am a clinical pharmacist. I practice in a critical access hospital. It has 5 beds, 5 inpatient beds, 9 emergency department beds. And so I still do some clinical practice, but not my favorite thing. We're also going to look at the clinically significant botanical legend drug interactions and talk a bit about their management. A few disclosures. I have no needed financial disclosures, other than I'm, like I said, a prostitute, so okay. I was actually laughing at Mr. Adams, it was actually the patient's, it was like, okay, well, here we go. Ethical dilemma, right? Anyway. We'll talk about some off-label use of medications. In other words, medication uses that are not FDA approved, but they are labeled as such. And I do include brand names to help facilitate that connection between the generic and brand names. As a pharmacist, I have a generic mind, but where I include a brand name product, I'm not like trying to advertise for anybody in particular. Okay, that being said, I have one additional disclaimer. I'm here hoping to learn from you because the only thing that I know is what I think I know, which is a much smaller part of my perception of reality than what I know that I don't know. So there's a whole lot more that I don't know than what I do know, and I reserve the right to be wrong. So I live right now, right here, in the middle of the opiate crisis. I'm originally from northwestern Pennsylvania. This other red dot. So I came from the opiate crisis to the opiate crisis, so to speak. In September released analysis, up to 33% of medical charts for allopathic physicians for whom opiates were prescribed had no documentation in the chart for a reason why those opiates were prescribed. They eliminated in this study any chart whose diagnostic list was too long and it might have dropped off because of lack of field space. So for those charts that reviewed, 1/3 of patients had no reason for, the opiate to be included. That being said, I've had patients in my practice. I had one patient that comes to mind in particular who had broken his arm 3 years before he was actually referred, this is when I was doing a lot of outpatient work, referred to the outpatient clinic for opiate habituation. He broke his arm 3 years ago and was still on hydrocodone 3 years later. So I don't know if you all are aware, but November 2nd, 2018, the FDA approved a submucosal form of sufentanil Dysuvia for pain management. Okay, a lot more potent than fentanyl, which is killing a lot of people. Mostly in Ohio. There's a bigger problem with fentanyl. I was really interested in this particular product because it was approved under the guise that, we have this patient population that comes to the emergency department who needs acute pain management, but for some reason we can't get an IV in. It takes an hour for that drug to work. Okay, so on one hand, we have capitalism. On the other hand, we have the opioid crisis. I'm not putting any of my dogs, of which I have 5 in that fight, but I don't really know the answer. So I'm here mostly, this is from the Institute, the International Association for the Study of Pain, multidisciplinary. UNDs are really why I'm here. Now, I'm a hick. I live in a place where there's one red light. The university is the only building that has elevators. For me, traffic on a daily basis is another car. A car! Okay, so I drove up here last week. It's quite an adventure for me. Where I come from in Tennessee, East Tennessee, they burn burn naturopathic physicians at the stake, I believe. Herbalists, naturopathic physicians, So I'm really reaching out because I think that you have the answers to the problems if we can all work together. That maybe we can really help the patients. Now you think about it, opium came from a plant, an herb. It's human nature, kind of, sort of, and maybe a little bit of capitalism thrown in. I have been, as I said, a pharmacist longer than some of you have been breathing. I remember when the Joint Commission for Accreditation of Hospitals came out saying, pain is the fifth vital sign. We need to sense everybody, give them all opiates, yeah. Okay, that was the 1990s. Fast forward to 2018, 2015, whenever, we now have an opiate problem. So I think that when we do unimodal approaches or even multimodal approaches where it's one person using their expertise and maybe even reaching out to things that they don't really understand and claiming expertise, that we get ourselves into problems. But if we all work together, maybe it takes a village to help patients with chronic pain. Maybe it takes all of us. Okay. So I'm going to start out with an overview of herb-drug interactions. This is what I teach. And so I'm going to talk about how herbs and drugs go bump in the patient, something that you probably already know, but not knowing my audience, I tried to make it a broad target. So when you have an herb-drug interaction, you can either get too much of what you want or not enough. The most simplistic and the easiest type of interaction to avoid is the pharmacodynamic interactions, those that occur at the level of the receptor that you're targeting, either with the herb and or the drug. So getting too much, you might have additive pharmacodynamic actions. So something like giving a patient kava kava or valerian while they're on a prescription benzodiazepine that are both CNS depressants, or they're on an opiate, you can predict that you're going to get a little bit more CNS depression sedation based upon a pharmacodynamic level. The more serious often are those that occur at the level of pharmacokinetics. Our phase 1, phase 2 metabolisms, our transporters, where we block efflux transporters like P-glycoprotein, will have drug accumulating in a tissue that we don't want it to accumulate in, and then causing adverse effects. If we have a precursor drug that is relatively benign, but it's activated to something toxic by the CYP450 system like acetaminophen, we can actually increase the level of toxicity of that agent. We can also have an inducing substance, in the allopathic world. The example is always a person who smokes cigarettes gets chronic obstructive pulmonary disease. We put them on the older medication, theophylline, which is a methylxanthine. They quit smoking because, oh my gosh, I've got COPD. The cigarette smoke induces CYP1A2, which is responsible for the metabolism of the theophylline. They quit smoking, the induction goes down, and then the drug accumulates and they get toxicity. So those are all things that can cause more than you expect. On the other side, antagonistic pharmacodynamics, where you have two drugs that are producing opposite effects at the receptor or functionally, changes in our absorption, our uptake transporters, induction of metabolism to inactive products. That's why, as much as I love brassica veggies, they're inducers of CYP1A2. My drug of choice is caffeine. So I'm trying to balance my 1A2 metabolism. I kind of like the caffeine to accumulate a little bit more. It's my go-tos. We can induce our active efflux transporters. We can also see decreased activation of a prodrug to an active drug. So some of these might actually be codeine, which is itself a prodrug that has very little activity until it's metabolized by CYP452D6 to its active conjugate morphine. Also, the older breast cancer estrogen receptor modifier drug tamoxifen is itself inactive until it's converted, to the active form by CYP2C19. Also, clopidogrel Plavix, which is an antiplatelet agent, is a prodrug that requires activation. The over-the-counter omeprazole type drugs also inhibit its activation. So that can happen. So a few important points. Number one, it's not always bad to have drug interactions. Sometimes we want that. Number two, drugs that undergo only a single pathway of elimination are much more likely to be problematic than those who have multiple pathways where the other pathways can pick up the slack. The individual phenotype plays a role. I was just speaking with Dr. Lee earlier about how if you go around the globe on a latitudinal basis, you'll find differences in our CYP450 isoenzyme polymorphisms, probably based upon what our ancestors ate. I am Eastern European, so I actually did the genetic testing. I am an extensive metabolizer of 1A2, i.e. caffeine, but also 2E1 acetaldehyde dehydrogenase. So I can drink lots of alcohol, never get a hangover, unfortunately. Highest rate of alcoholism because we don't get sick. And during the luck, I also metabolize caffeine very extensively, so it doesn't keep me up at night. So that being said, another caution, and I and a couple of my colleagues are currently working on a publication looking at herb-drug interactions, and one of the problems we're running into is a lot of these citations in the literature, even the databases like Lexicomp's drug interaction database, are based upon ex vivo or in vitro studies. The issue is that you're not looking at the full complement of metabolites. You're not really looking at the capabilities for enzyme induction. It gets really difficult to interpret things that you're doing in a petri dish and then translating that into an actual effect in human beings. So we're trying to substantiate herb-drug interactions from reports in the literature of actual cases. Now, of course, there is a bias. There's a huge bias here because all of the things that we're finding so far are about how herbs impact drugs. I'm actually a little bit more concerned about how drugs impact herbs. Because if you look at nature and the natural, the plant having everything that we need. I think of dandelion as one of my favorite examples. It's a diuretic that contains potassium. It has everything that you need in it, and the right balance of ingredients. When you take a super concentrated single molecule, you're going to disrupt that balance that's inherent in the plant. But there's very little reporting on how drugs interact with herbs. We come from an allopathic mindset where we want things to be reproducible in order for it to be evidence-based medicine. I'm not even putting my dogs in that fight either because to my mind, okay, I can reproduce this as long as I have this standardized population with the same phenotypic background and none of these other comorbidities. If I do the same thing over and over, I get the same result. That makes it evidence-based. And of course, that translates automatically to this whole room, to all of our diverse genetic backgrounds, our different dietary habits, our different behavioral habits. So sorry I got off on that tangent, but that's what makes the literature so hard to interpret. So from the PowerPoint, at the base of this PowerPoint, I did post two of the FDA website for substrate inducer and inhibitors, as well as the University of Indiana's Flockhart table, called the Flockhart tables. They list the drugs that are substrates, inducers and inhibitors of the different CYP isoenzymes. I also put together a few tables based upon my research for you that I'm not going to, if you look at this PowerPoint in advance, I'm not going to read every slide to you, I promise, so don't, but that's my students are always like, oh my gosh, Babis, you put in 62 slides, we only have 40 minutes. It's like, well, the FYI slides, the tables where I summarize it for you, I don't read. So that being said, let's move on. Woo! So characteristics that make a drug high risk. Notice I'm focused on drugs. I am a pharmacist. Sorry, prostitute, whatever you want to say. If a drug is toxic to start with, it's something a little bit more to worry about. So warfarin, for example, besides the complex metabolic pathways, the complex polymorphisms in the vitamin K epoxide reductase, if you get too much warfarin, you bleed. If you lose your blood, you die. Okay, that's bad, right? So that's going to be a high-risk agent. The opposite is also true where you have drugs who need a high level to maintain efficacy. So our antiretroviral cocktails, if we don't maintain adequate suppressive levels of these drugs, if we induce the enzymes that metabolize them, the drug goes away, we get development of resistance. So we can, get resistant infections. The drug undergoes multiple metabolism by a single pathway. It's more susceptible, or it's selectively secreted by an active transport pathway. If there's a lot of variety in the pharmacokinetics between patients, and then again, if the transformation causes toxicity. Other considerations with our botanical product, we have to think about quality. I know that Mr. Adams brought up, do you sell products, do you sell products for patients? And I was really kind of gratified when he put the information up there saying, we've got to do it in a way that protects the patient, because I'm certainly not going to go to the local discount store and buy an herbal supplement off the shelf. Who knows what you're getting? So what is in there matters. Is it the active ingredient? In the case of hyperforin, they found that when there's less than 1 milligram per dose, they're probably not even inducing any enzymes. But we also have to think about contaminants. Also, how long the product's being used, because when we have enzyme induction, that doesn't happen overnight. It takes repetitive administration, activation of those pregnane X receptors, as well as, our aerohydrocarbon receptors, to cause more copies of that enzyme to be produced. We have all those confounding factors. We have temporal bias. So I'm a patient, I come to you, Dr. Giardinelli, I'm seeing my regular allopathic practitioner. I come to you and I fall down and I hit the wall. I'm gonna blame the herb, whether or not, or even if I fell down and hit the wall, and then I come to you and, oh, now my shoulder hurts, it's your fault. So, the human mind has that temporal bias where we want to affiliate cause and effect, whether even temporarily it makes sense or not. And finally, we always have to consider the patient characteristics. So tips from a crusty old pharmacist. Number one, be suspicious. If you see more than you expect from your treatment plan or less than you expect, start to think, okay, maybe there's something wonky going on besides patient adherence. Know where to look for information. Well, that's kind of good. If I could sit up here and tell you where to look, great. But I mean, so you're looking at databases that are available that may or may not be based upon actual patient experience. Again, a thorough medication and herbal history, adequate charting. I can't tell you how many times as a clinical pharmacist I'm looking at a patient's chart. Nobody's even asked them, name all your practitioners. Do you take any herbal products? That's not something that allopathic physicians generally assess. And then avoidance. If you know that an herb is a high risk or you see on your patient's med list a high risk medication, start thinking about looking things up before you prescribe, and then consider that multimodal approach, consulting the provider. This is from Horn and Hanston, who are like the gurus of drug interactions. As a clinical pharmacist, when I practice, if they're asking me to evaluate a drug interaction, this is basically what I use to get some type of objectivity towards the probability of it actually being a drug interaction. So anything above an 8 is probable. If it's less than a 2, probably not, and then anything in between. Okay. So here's a case report. We have a 19-year-old male who's presenting to the the emergency department. His temperature is elevated, his pulse is elevated, his respiratory rate's elevated, his blood pressure is slightly low. He's agitated, anxious, he's got tremor. On neuro exam, we find inducible clonus. He's diaphoretic. His skin is flushed and sweaty. He's ataxic. He's a frequent marijuana and ecstasy user. And then he's reporting recent use of St. John's wort and tryptophan for a detox. What's going on? Serotonin syndrome. Yep. So this is a classic serotonin syndrome. St. John's wort, while we often think of it being an enzyme inducer, is also a pretty powerful serotonin reuptake inhibitor. Tryptophan being a precursor to serotonin. Methylene dioxymethamphetamine or ecstasy is serotonergic. It blocks reuptake of serotonin also. So here we're seeing a classic case of serotonin syndrome. If you forward, please. This is from an older article in the New England Journal of Medicine, but it gives you the symptoms of serotonin syndrome, and indeed it can be life-threatening. The case of Libby Zion, I think it was the late 1980s, a patient who went into the emergency department on phenelzine. The resident physicians prescribed meperidine, a pain medication. She died of serotonin syndrome. So even medications that we don't intuitively know or products that we don't intuitively think of as being serotoninergic can be implicated. The herbs that are of concern here, of course, the dietary supplement tryptophan, the amino acid, St. John's wort, Panax, ginseng, Syrian rue, and then also Passiflora incarnata, probably because of the harmine, low levels of monoamine oxidase inhibition. If you have patients who are interested in ayahuasca, the copy vine is also a monoamine oxidase inhibitor. So if they're on a serotonergic medication, that might be something to consider with serotonin syndrome. So this is one of the rare, potentially fatal, like pharmacodynamic type of effects. Most of them are going to be more pharmacokinetic in nature. So let's look at the anatomy and physiology of pain. Oh, by the way, if you want to, if I'm wrong, please stop me. The worst thing I can do is misrepresent something, or if you have a comment, please stop me. I'm not, I'm here for you. I really am. Okay, that being said, definition. Nociception is simply the thing that happens at our peripheral receptors that detects pain. We also have pain, which is different than nociception because pain involves that complex integration in higher brain centers, the emotional response, the neuroplastic responses that can occur to pain. Pain is pivotal to existence. We found that mutations where patients aren't able to nocicept cause death. When people can't feel pain, they have a higher incidence of early death. Excuse me. So we have these ascending nociceptive components, our nociceptors, which activate our A delta, which are lightly myelinated, slightly larger neurons than our C or slow fibers. These neurons go to the dorsal horn of the spinal cord. They have their cell bodies in the dorsal root ganglion, where they synapse with an interneuron that crosses to the contralateral side before it ascends in the anterolateral ascending pathways to the CNS. If you think about first pain, second pain, you bang yourself with a hammer. Ow, we get that sharp, intense throbbing pain, followed by a little bit later, oh yeah, that really hurt. It was kind of interesting though, the gait theory, Matzak in 1965, brought up when you do this, after you bang your finger, the tactile, the A beta fibers gate out the nociceptive signal. I mean, that's why we want to rub something after we injure ourselves. So that's the gate theory. Most of our rapid afferents or A deltas are glutamatergic in nature. They release glutamate to activate an NMDA, usually AMPA receptors first, and then NMDA receptors at the level of the dorsal horn. And we also have other interneurons in the dorsal horn that may be glycinergic or GABAergic that are actually inhibitory. So we're going to start out looking at the nociceptive signal. So if you advance to, start there. Here we go. This is our primary neuron. From our free nerve endings. Our pain nerve endings are free nerve endings. Unlike the Meissner corpuscles and the Basinian corpuscles, these are free nerve endings. And you guys jiggy with transient receptor potential channels? I mean, I'm sorry. I'm a molecular person. I like to think about things on that level. So as you'll see here on the diagram, we have the TRPs, which are transient receptor potential channels. They're ion channels that are either unimodal or polymodal. And when they sense something noxious, they allow cations in, usually sodium, sometimes calcium. We also have the acid-sensitive channel. We have various G protein coupled receptors that also activate the influx of cations that start an action potential down that primary neuron towards the dorsal horn of the spinal cord. Along the way, the action potential is continued by the influx of sodium, largely through sodium voltage gated channels, including NAD 1.6, 1.7, 1.8, and also 1.9. Might as well throw that one in there too, why not? 1.9 has a tendency to be a little bit sensitizing. So the action potential is going to travel down to the postsynaptic or the presynaptic part of that primary neuron, where the change in voltage activates voltage-gated calcium channels. When those voltage-gated calcium channels are activated, the glutamate is released that sends a signal across the synapse to activate one of the glutamate receptors on the receiving postsynaptic secondary neuron. Woo! Okay. Oh, we went to sleep again. I'm sorry, I didn't mean to be that boring. I even put the projector to sleep.
I don't know if it's overheated, maybe.
One of the things about that voltage-gated calcium channel is that with continued activation of that neuron, we get expression of what are known as alpha-2 delta subunits that dock more of those voltage-gated calcium channels to cause even greater influx of calcium and release of more glutamate. The other thing that happens with activation of the TRPV1 type of ion channel is that the TRPV1, the capsaicin hot channel, if you will cause release of both calcitonin G-related peptide and substance P. Both substance P and calcitonin G-related peptide are part of a sensitizing soup. And I'm sorry, I'm just smiling because I can break any, I can cause the ruination of any technology.
Might be overheating.
I think so too.
Okay.
We'll figure this out.
Okay, that means that I'm just such a burning presenter that I overheated the projector.
Do you,
No
need,
worries.
do you want to use my laptop for a minute? And then we can kind of keep it moving and then I can get
Yeah, no,
replacement.
I'm just as happy to keep moving, so
Okay.
I don't know what this does for you.
Anyone have a little laptop
Oh,
that she
okay.
could use for a minute?
I have mine in the car, but of course I didn't bring it.
And then I will switch a Ruby on this in a minute.
And now comes my favorite part where I get to act out what's going on in the neuron. Woo! I'm good at that. My favorite lecture of all is talking about margination. Thank you. My favorite is when I get to talk about margination of white blood cells. I get to roll around the room. That's my favorite. But I know this isn't a topic on inflammation per se. No worries. So I'm not going to marginate for you. So as I was saying, when we activate those TRPV1 receptors, our TRPV1 and our TRPV3 in particular, TRPA1. Woo! All right, we'll put it down here. When we activate those receptors, our TRPV1, our TRPA1, they desensitize. So what we can get is agonists that initially cause pain, followed by decreased nociception. Our TRPV3 receptors have a tendency to sensitize even further, although I want to read more about this because there are active ingredients in boswellia, myrrh, for example, are considered to be agonists of that TRPV3. And I know from personal experience that they are pretty anti-inflammatory, so I have to do some more research as far as that goes. So at any rate, we have our, sorry, I'm just orienting myself, here we go. We have our sensitizing soup that occurs. I alluded to the fact that our TRPV1 release calcitonin G-related peptide CGRP, and substance P. But we also find our immune system involved here, our mast cells, our neutrophils who are releasing a lot of inflammatory cytokines, tumor necrosis factor alpha, interferon 1 beta, for example, that actually can cause increased sensitivity of these nociceptive neurons through phosphorylation, but also can change the genetic transcription to the point where we're inserting more of these transit receptor potential gated ion channels into the neuron. So we become much more sensitive to pain. This is in part known as peripheral sensitization, part of the allodynia hyperalgesia pathway. Okay. Oh, there we go. Woo! It's magic. No, it's not. Okay, I can't seem to make it go beyond the slide. Oh, like I got it. Is it a touch screen or? No. I'm just such an old person. I'm really grateful for, oh, thank you. I'm really grateful. You're magic.
Is that where you are?
That's right. Thank you so much. I actually had to have one of my students put my phone on large font so that I could text. It was like all of a sudden I'm a cool kid. I can actually text because, that's what happens when you get old. So an important concept is that our lipid metabolites are,
It's cold outside.
yeah, I mean, I'm sorry, I'll take that one and run, because I came from East Tennessee, and my husband had the doors open, it was 70-some degrees. And I came here, and of course I didn't bring a coat, I came in sandals, except I went and bought some shoes. A little bit different in temperature, even though I'm at a slightly higher altitude. But nonetheless, I survived. So here we are. One of the cool things about these transient receptor potential nociceptive channels is that they are greatly modulated by our lipid metabolites that come from that lipid bilayer in our cell wall. We're probably all familiar with the arachidonic acid metabolites that lead to formation of the inflammatory prostaglandins. What we sometimes may or may not realize is that our endogenous cannabinoids are also modulators of the TRP channels, especially TRPV1. So we have this built-in system that can either increase or decrease sensitivity of these nociceptive neurons that are in part, many of these modulators are at least in part derived from that lipid bilayer. So to talk about just a few of the selected TRP ion channels, anybody here familiar with Euphorbia resinifera toxin? This is a plant-derived isolate that is actually a modulator of TRP M3. That, is it M3? I believe it's M3. Permanently disables it. So we're looking at the use of this Euphorbia plant derivative to degenerate the neurons to treat chronic pain in the allopathic world. Just another, one of the allopaths' desires to take over your world. No, sorry, I don't mean to talk like that. So I'm going to be challenged again. Did any of you treat any patients with taxane-induced cold allodynia? So the taxane derivatives from the Pacific U actually permanently can bind to some of these TRP receptors and cause that cold allodynia. So patients, what we'll find often is the neuropathic damage done from administration of Taxol or docetaxel, which is Taxotere, can lead to permanent neuronal damage where even brief exposures to cold can cause a severely painful response. So this is actually funny. I had to do my job interview for the teaching position that I have now, and during it, the computer failed. And I got the job because I kept talking. Woo! All right. I've got it. I have a practical experience in this.
Look at the guys are gonna.
Oh, there we go. Let's see. Hey! Now let's have an ethical discussion. Oh, there we go.
Which one? Right here?
I'll go one more. There we go. Okay, so there's our lipid metabolites. I'm going to return your laptop here before I destroy it too. Thank you for letting me borrow it. I just think this is the coolest thing ever, in that our endogenous cannabinoids, everybody, we had a discussion earlier about cannabidiol. The cannabinoid system, as we'll see thankfully for you guys, right towards the end of this discussion, is much more intricate than just the cannabinoid receptors. Our endogenous cannabinoids, and even the cannabinoids that are in cannabis sativa, actually modulate pain at the nociceptive level. So I just think that's pretty cool. So my students, I work in an allopathic environment, and many people are very rigid in their mindset about cannabis and herbal medicine, and we happen to have a cannabinoid receptor signaling lecture on April 20th. 420 day. And I didn't know what that was. My colleague is much younger than I am. And they, yeah, we have to talk cannabinoids. It's really important that our students understand this because these are going to be medications. They're, patients are using them, and it fell on 420. And so I'm up there, I'm lecturing about cannabinoids, and like the students are snickering. I don't know, okay, whatever. You have toilet paper or some what? And so finally, my compatriot told me what 420 was. Anyway, so I talk a lot about cannabinoid receptor signaling in my pharmacology lectures. So I think my students are fortunate in that I am not going to have prejudice against a plant. Sorry. Now, what is that with people that one group of people thinks they can legislate what plant another group of people can use? I don't know. In Tennessee, kratom is also illegal. So, okay, we can move on. I'm sorry. I keep going on these sides. We can go one more. Okay, we talked about the taxane cold allodynia, but just in case you're not aware, TRPA1 is one of those that desensitizes after activation. So your hot wasabi, your hot mustard, curcuma longa, the curcumin are all TRPA1 agonists, as is gingerol, ligustolide. Parfenolide, feverfew, is actually an antagonist. You can get both agonistic and antagonistic activity. You can downregulate signaling through that TRPA1 receptor, both by turning it on and by blocking it. If we move on to our TRPM8, that's our menthol, our cold receptor. TRPV1 is a polymodal. I find it particularly fascinating. Capsaicin, racinoferatoxin, piperine, eugenol, and clove oil, zingerol, and ginger. Many insect and snake venoms actually activate and modulate the TRPV1. So why not make a TRPV1 antagonist? It causes hyperthermia almost predictably. That we get a hyperthermia when we use a systemic TRPV1 antagonist.
Thank you. We can leave that as a backup just in case. Thanks so much.
I can break that one too, I bet. Woo! Thanks really hard. Okay, so we can go ahead and move on. So as I said, I'm a bit of a chemist. So the vanilla moiety, which is that ortho substituted dihydroxyphenyl group, as we see the vanillin all the way to the left, capsaicin, racinoferatoxin, piperine, eugenol. Cannabidiol is actually a para-substituted hydroxy, and it is an antagonist at the TRPV1. And then anandamide is our endogenous agonist. So the other part of my presentation today is dealing with drug interactions. So this is what turns on our TRPV1. So if you move one slide forward, we'll see what predicts inhibition of our CYPs. Those plant constituents that can treat our pain also mess with our ability to metabolize them. So, I hold with the precept that the cannabis sativa plant makes, a lot of the terpenes and the cannabinoids, if you will, that are in it to protect itself against invasion by nematodes. We're hopefully a little bit higher of a life form than a nematode, although I don't know, because nematodes don't generally destroy their planet, right, like humans. But nonetheless, we have this, we've all evolved together, so to speak. So the things that turn on our neurons, modulate our neurons, also mess with our body's ability to get rid of them. So this is predictive of CYP inhibition, and if you go to the next slide, looking at curcumin, piperine, and capsaicin, the piperine has a methylene dioxyphenyl substituent, but also curcumin and capsaicin, while they don't have the ethoxy ring, they're also fairly potent inhibitors of some of our CYPs. Most notably CYP3A4. We see that even without that methylene bridge, we get a pretty significant inhibition. So what am I saying? Okay, we all know piperine we can use to enhance the absorption of other constituents. Part of it is at the level of P-glycoprotein inhibition. I posit that part of it is also through decreased metabolism of some of those other constituents. As we'll see when we get to the NSAID slides later, there is, why not if you're going to take an NSAID, why not take it with black pepper? You're going to get a bigger bang for your buck. So at any rate, there is this molecular homology that predicts both the efficacy at some of our TRP channels, as well as the potential for interaction at the level of our stiff isoenzyme. Okay. Looking and moving on to the voltage-gated sodium channels, really, really integral to many of our pain syndromes. 1.7 and 1.8 are going to enhance the current in 1.9, and 1.8 and 1.9 are going to be upregulated in inflammation. You can see towards the bottom there, 1.2, multiple sclerosis pain syndromes. The main point here, to one that's not on the slide, one that is, but our anti-epileptic drugs in the carboxamide class, this is their target, is sodium, voltage-gated sodium channels. I don't know, any of you use pedicularis or delphinium for pain? Okay, so the aconite and the
Actually, yes.
delphinane
I'll use that.
are actually Turner honors of these sodium channels.
Uh-huh.
So when we're talking about the anti-epileptic drugs, they turn it off.
That's the same way it can kill you, aconite, yes.
Yes, the aconite type derivatives keep these sodium channels propped open. So I can see that as a potential pharmacodynamic interaction where you're going to have counteracting effects. Yeah, but so your aconite derivatives can kill you because of those increased sodium currents. Your carboxamide derivatives can kill you because they block them. So tetrodotoxin also from the pufferfish blocks those sodium channels. So wind up. So basically wind up, if you hear about wind up in the concept of sensitization, basically what this means is that it is an increased sensitivity to pain signaling that is not at the level of gene transcription. In other words, the hydroxylation or the phosphorylation of some of those TRP channels, when we activate our NMDA glutamate receptors, they in turn kind of activate themselves, so to speak. So we get basically an enhanced level of signaling that can temporally summarize over time that further increases the signaling to the dorsal horn of the spinal cord. Once we get to the dorsal horn of the spinal cord and we start activating the NMDA receptors there, then we start enhancing central sensitization, which is what's known as long-term potentiation. We're altering the expression of the receptors and the pathways in the brain that cause the patient to feel more pain than they would had it not been a chronic pain. Okay. So I was talking about calcitonin gene-related peptide earlier. I got a little bit out of sequence. Just FYI, 2 new drugs that were approved this year by the Food and Drug Administration. We have, here we go, fremanezumab, which is an anti-calcitonin gene-related peptide receptor antibody. It's going to block those CTRP receptors. We also have Aimovig is the brand name for arenumab, which is an anti-CGRP. It's an antibody against calcitonin gene-related peptide itself. Now, I don't know about y'all, but like calcitonin gene-related peptide. Let's see, calcitonin in the body, all of the things that it does.
Right. Yeah.
And now we're talking about its receptors or it.
Right. Seems problematic.
I can't wait to see in about 2 years, does this drug make you grow a third eye in the middle of your forehead? I mean, what are we going to find out?
Aren't longer than 12 months on that, right?
Correct.
I have
Yeah.
a patient on this right
I did too.
Yeah, I want to.
I didn't get
right
it
now.
too.
Seems problematic though.
I don't know how aware you are of the drug development process in the United States, but we have phase 1 preclinical, phase 2, we're really looking at pharmacokinetics. Phase 3, we're actually looking at the drug in people that have the disease that we're targeting. Phase 4 is like, hey, let's put it in the water. Yeah, see what happens. Okay, so your patients who are on this right now are those phase 4 guinea pigs. There is, and I don't even know how this works. I don't understand licensed on licensed providers, but that's rhetoric that's way beyond my pea brain. But for rare adverse drug effects to get in the package insert from the Food and Drug Administration, it has to be voluntarily reported to the Food and Drug Administration. Okay, how many people take the time to do that? I mean, I actually just reported, I had a patient come in, it's another long story, with protracted pain from a treatment for Crohn's disease, and I filled out the MedWatch form. That drug company calls me every day. And I'm like, dude, I'm just like a clinical pharmacist. I'm just trying to play middleman. I've called you to find out if there's anything I can do to help this pediatric patient whose physician gave her this medication off-label, who now has intractable pain. I'm not the physician. I can't compel them to report to you. People don't do that voluntarily for a good reason. So those of you who have patients on these meds, if you do notice something that you suspect to be due to one of these meds, please report it. Get your local pharmacist to report it if you can't access the MedWatch database, because it really is important, because we don't know. They just finally came out in 2015 that acetaminophen can harm you.
Right.
All right. So I'm just saying. Okay, we can move on. Also, how are we?
It's 2:14. I think maybe we'll stop in about 10 minutes.
Okay, just give me a.
Okay.
So integration of pain. So we talked about from the nociceptors to our dorsal horn. Now we're moving up. Excuse my terrible. I'm not an artist either. I have done occasionally presentations that are for a for-profit, so I had to do my own graphics. That's where this one came from. So we have our signal. We have essentially these two pathways that are coming from the nociceptors. One is the nociceptive reflex, which actually just, you go from the nociceptor to the spinal cord and right back to take your hand off that hot stove, whatever. The other signal, the one that goes to the brain, there's actually two pathways that go up that anterolateral pathway to signal to our higher brain centers, the anterior cingulate cortex that makes us have that aversive response to pain, our amygdala, actually before it even gets to the ACC, our amygdala, so that it can modulate pain should you need to lift the car off your foot in that stress response. The insular cortex, which is going to be responsible for processing of visceral pain. We have descending signals from these upper central regions that can either increase the level of nociception or hopefully decrease the level of nociception. So go ahead and move on. So I mentioned the gate theory. That's where the rubbing of the injured joint overrides, if you will, the pathway to the brain that's trying to signal pain. Our amygdala being partially receptor for gating at the periaqueductal gray area that surrounds that central aqueduct in the brain itself. Our periaqueductal gray is responsible largely for release of endo-opiates, for endogenous opiate signaling to reduce pain nociception. Our cannabinoid receptors, or CB1s, inhibit the GABAergic inhibition of that periaqueductal gray. In other words, there's a synergy between cannabinoids and our endogenous opiate system and any exogenous opiates that the patient might be on. So our rostroventral medulla has multiple signals. It has on neurons that actually turn on nociception and off signals that inhibit that nociception. The off signal is normally tonically active, but when we have that central sensitization, the off cells get turned off, the on cells get turned on, so that the patient is always in that heightened nociceptive state. We have signaling downward from that periaqueductal gray area to the locus ceruleus that releases norepinephrine. The locus ceruleus, as far as we know, as far as I know, always inhibits nociceptive signaling. It also is going to disinhibit the Raphe nucleus. A Raphe nucleus being the primary source of serotonergic signaling in our CNS. And serotonin can either be excitatory or inhibitory depending upon the chemical milieu that's also in the environment. The cool thing about the anterior cingulate cortex is that it's probably involved in the placebo response. I don't know about y'all. How do you feel about placebo?
I love it.
I do too. I mean, I know in the allopathic world, they're like, that's just a placebo effect. And I'm going, dude, if I hurt and it fixes it, I don't care, okay? So right now it's considered unethical to prescribe medications in allopathic medicine because of the placebo effect.
Probably
let's give opiates instead. We know that's way better, right? Okay. We can go ahead and move on. This is just talking a little bit about wind-up and neuroplasticity. So, as I kind of alluded to, not very effectively, sorry, but when we're starting to get that wind-up going on, we're starting to release enough glutamate at the synapse that we're activating the NMDA form of glutamate receptor. That causes an even greater influx of calcium into that secondary neuron. That increased calcium does many things, one of which is activates phospholipase A2, which is going to snip off part of the bilipid membrane to produce things like prostaglandins that increase inflammation. It's also going to increase the activity of both neuronal and inducible nitric oxide synthase, which then generates reactive oxygen species, which then does further neuronal damage. One of the scariest things, too, is that it's going to alter kinase activity that ultimately leads to alterations in genetic transcription and translation that then actually alters synaptic morphology. So when we have this constant pain, by itself it winds up, it increases its own ability to cause a pain signal, which eventually leads to rewiring of the neuron itself through changes in the genomic expression so that the patient is at a heightened risk for feeling pain. The top is another one of my poor graphics. This is just my interpretation of allodynia and hyperalgesia. So we have the black line, which is a normal pain response curve. Anything to the left of that dark black S-shaped curve is not normally painful. Once you hit that level of response on the x-axis that begins to hit that black line, you start to see pain as measured on the y-axis. When we have this peripheral and central sensitization, this wind-up and long-term potentiation, we shift that black line to the left, such that even normally non-noxious stimuli causes pain, and a noxious stimuli causes an enhanced perception of pain. Okay. A good point to stop.
Yeah, I think it would be,
This is about halfway.
how many slides did you have?
I have I think there were 100 and some, but there were five
I think you're
pages.
about halfway. Yeah.
Yeah, no, there's a whole bunch that are just resources.
Yeah, we'll take, can we do maybe, since we're a little bit behind, maybe a 10-minute break?
We can, whatever, because I can, they don't call me babbles for nothing. I can talk faster than any 10 people put together.
10-minute break is good for everyone. That's a good idea.
Yeah, let's turn it off.
I'm sorry about that.
There's gotta be some good parts.
I don't have any good pharmacists. Pharmacists are not fun people. Like, we all have our ties knotted just so, and our eyes. I'm not a very good pharmacist.
So we all-
We'll be back in 10 minutes.
Because most pharmacists are very meticulous.
Yeah.
Oh, yes. I'm kind of like, woo! That smells good.
Yeah, I think it gets overheated, so
And I have Renaud, so when I'm nervous, I can.
Oh, yeah.
Oh, but I don't feel so bad.
It's so bad, like, it didn't stop ordering.
Yeah. So where did you do your MD training?
My program doesn't really exist anymore because it was like.
You think it'll read us, Sarah? Okay. Oh, we can do that. I'm good. Sometimes I skip because it's not as. And you can also move up.
It was actually like way
Is
better.
it a mess of the video?
No, the audio's over there.
Yeah, that's probably
A
not.
little bit? Yeah.
I wonder if.
Let's start out the back.
We
Maybe
should
just move this up a little bit.
have like a flip.
Okay. Now they come,
And then we can just readjust that situation.
I just want it because I know it's going to be challenging otherwise.
Yeah, it's all good.
Okay.
All
right,
great.
Sorry, ladies. But then she can. But she I'm gonna go run this.
She's like one of the.
So back in the day, we were all compound pharmacists. There was no such thing as a non-compounding pharmacist. So when it came to herb school and it was like, you know, when we did the medicine making, I was just like, oh yeah, and everybody else was like, it's like, I'm this. So this is one thing a pharmacist taught me that is obvious.
Yeah, they're green out there. You don't know any of those guys?
I'm from Tennessee, so I don't really have a lot of local connections.
Let's talk about Leesburg compounding center. Pharmacists.
Do you know Sarah Melton? Sarah Melton?
Sarah Melton, that made me
She works at ETSU. She I know, She like trains a ton of people around.
I think that might actually.
How did you know her?
So if you saw that, you get your drivers.
I usually I know.
And I'm not really a big mind on you. You know what I mean? I'm just talking about this. No, but I'm just not. I'm not your
So.
Yeah, I'm not. This is the rest of next week.
Yeah, it's far. So it's kind of confusing, especially like.
They become hormone sensitive.
Well, that's like actually just my experience, probably that like you. So, I mean, I don't know. My sister's a hospice nurse.
Yeah.
So I'm trying to research why there's a lot of things personalized, and I'm not saying.
So like this is just a sleep score, and it has just in your HRV, activity and intensity, the use ratios, general activity, it's really,
Exactly.
They have a little bit.
And then we're so consistent.
And the initial research, so your the research is that we're doing, you know, it's not fancy, they're everybody's getting well, yeah, it's like.
And then just,
So I just wonder, but just to look at the dialogue, we get everything.
when's your birthday? That's the other thing, when's your birthday?
As far as your, I'm a virgin,
Okay.
and except that I'm not,
You don't seem to.
I am not, but I'm like a Leo Virgo.
Yes,
So I have technically Virgo, yeah, I mean, I'm not exactly thinking about that. But I'm not, the part of Virgo fits that perfectly. How do you want to be like that? Hell no!
So, you know, let's assume right now we
And that's why I'm a lot of, well, a lot of reasons say that.
actually, that's the point. So the liquid, there's the answer.
Yeah,
So
yeah.
this is the. I think we have,
I'm not saying that I can't, or I was just like,
You know, Randy Ballmer, he's just, actually the science chair.
so we can sweep the leg.
So he
Yeah, so you get up to those days,
Yeah, Wednesday, let's say number 3.
bottom line is we have physical
What's goes on?
Yeah, so, We have,
I don't want to think about it.
So they would actually, they would actually share publish that on social media.
Actually, I'm doing one with veterinary
easy practice of this.
Well, that's where the bags are, right?
Or it can be so ours are full spectrum. Oh,
It's an easy way. Read it. That worked well. It was only like 10 questions. Like,
well, I'm gonna give you a point. So logos.
I mean, I could send
Nice. She doesn't care about kids. I mean, she doesn't care about people. No, she cares about people.
So it's mitigating anxiety. Non-inducing drowsiness. When you exceed 50, he said you shouldn't be individual. Exceed 50 milligrams, small sober. So it's gonna help us. And even if you can use it in really high dose. Now, so those are, that's the dose that
I know, right?
Which is crazy. Yeah.
Just because we need it.
That's the initial, so I'm gonna like use actually, what we can do is point to all the science, and then you can refer the application. Well, this potential is expensive. So, that's gonna be like.
So here.
So I don't worry about something like this.
So you'll see like, I know, right?
So this is 15 times 3. So it's confusing.
Yeah.
That's like
Oh, yeah.
Not the night before,
Well, I'm sure they do. When you're running trials,
Yeah.
and then you see the win.
And for me,
So right now, you're gonna see
that's
that would be 4 hours. And I do this is at an minimum one question. Every patient the next one. I do 4 of these. I'm getting 4 programs of 10 minutes. And we get 3 hours.
Yeah, I know, yeah.
3 questions, so.
Why do you call it soccer call?
There's a synergy certificate and this is where we're getting into just our basic understanding. It's just a trace. And because it's a low ratio, you can just use one of these at 10.
So I don't know.
Yeah.
So I like the bigger girls, I like the less snow.
Oh, yes.
Okay, so that's what it is. When students are doing.
Yeah, related, another new program. Yeah, so.
Hello, I'm gonna draw for the raffle. Who has a ticket number ending in 117? Oh, let's get one. Yeah. Not you? Well, if there's no one, is it me? It's me! That's awesome! But let's just do a redo because I don't think. No, I don't think that. It's a homeopathic. It is 1, 2, 1. What? It's a homeopathic professional kit or three bottles of Mega Biospore. Okay, and then we have one more.
That's awesome.
Thank you.
For this one.
Okay. And thank you to WHP Homeopathics for the professional kit and for sponsoring our event as well. 117, that's me again. 121, we already did that one. I need somebody else to shake this. 1, 2, 0.
No, that's me, but I can give it to someone else.
Okay.
Give it to someone else.
Okay. 116. If they're not here, they don't get it. 114. Okay. Woo-hoo.
And you can give him your.
Okay.
Good to go. Okay. Speak like a back in. Okay. I really like Mr. Adams' small group thing. I was thinking, how can I adapt this for that? That'd be a toughie though.
It's challenging with the people remote too.
Oh, I forgot
And then I
about
tried to
remote.
Zoom it, and then it was so loud, it was giving feedback. I'm like, I don't know what I'm doing.
Oh, I forgot about the remote people. I should say hi to them, huh?
I think they're still on. At least my friend Alicia is.
I do, because at med school now, attendance is mandatory.
Oh.
So we do a lot of media studying where.
It's not, it was mandatory for us after the kids because.
TA school is, but VO school is not.
So do people go to lectures?
Some, but out of our class has 50. And maybe 30, 40 people.
That's a little scary.
So the media side.
Oh, okay, so it's
So they can
remote.
pause and.
That's nice.
Yeah.
Okay, so it's not like they're not watching.
No, it's recorded.
Got it. Okay. All right. You're good. Okay.
So I'm sorry, I forgot there was people out there in, what I'll call media site land. I was just telling Dr. Giardinelli in osteopathic school, at least where I work, attendance is not mandatory. They record all of the lectures. I was also speaking to Omar, who is another Pennsylvanian, by the way, originally. We were talking about snow in Tennessee versus snow in Pennsylvania. So I missed my first day of work ever because of snow in Tennessee, and I went, 2 hours shopping. I drove because it didn't snow. They just canceled things because of the threat of snow. Whereas in Pennsylvania, you get 4 feet of snow overnight, and if you don't show up, they fire you. So, woo! That being said, hi to everybody who's at home. Just briefly, I'm going to cover the current standards for pain management in allopathic medicine, just because, I guess because that's what I'm supposed to teach in my world. So per the American Pain Society, always establish realistic goals with the patient. And I had this discussion with some of you at lunch that people expect to be pain-free when they're treated, and that's just not realistic. If you tell a patient that you're going to be pain-free from this medication, that medication is not going to work. That treatment is not going to work. So even in the allopathic realm, we should not be trying to promise that we're going to make patients pain-free. We need to educate the patients. And interestingly enough, the American Pain Society says use the World Health Organization ladder for pharmacologic pain management as well as non-pharmacologic pain management. This is not evidence-based medicine. Okay, the World Health Organization pain management ladder is not evidence-based, but it's still what we say to do. Number one, start with non-opioids, topical anesthetics. Step one, at a moderate level of pain, a moderate level of pain, use your step one plus as needed opioid, maybe nerve blocks, other procedural interventions, and then not until you have severe pain, you start using scheduled opioids around the clock. Okay, we can move to the next.
Question for you. Is there any, if we were going to do an evidence-based method, is there any enough evidence to base a method out of? And if you don't mind repeating the question, for that.
So the question is there any evidence-based ladder for pain management, so to speak? And what was the second part?
Oh, yeah. If so, what would that be?
If so, what would that be? To the best of my knowledge, I have yet to find an evidence-based pain management ladder that actually is based in, yes, this actually works, as opposed to anecdotally. What I do have included with every pharmacologic class is a summation of the evidence to support that class. So as we move on, we'll see some of those, but to be honest with you, the evidence that we have for most standard medications is not great. So guidelines for opiate use, pretty much common sense. In both Tennessee and Virginia, a history of physical exam in person are required. Some states do not require the physician to actually interact physically with the patient. this CDC guidelines don't necessarily require that. One of the things that I really think is important for a multimodal functionality is understanding what morphine milligram equivalents are. So in the allopathic world and in the Veterans Administration hospital facilities, they evaluate all opioid medications on morphine milligram equivalents. Later in the PowerPoint set, I have a conversion chart for your reference. But basically, anything above 50 morphine milligram equivalents per day is considered high risk for both addiction and or potential overdose. And that's a point at which the CDC and the state of Virginia recommend prescribing naloxone to the patient should they inadvertently overdose. The CDC guidelines state that you need to consult with, if not refer to, a pain management specialist at that 90 mmE per day level. Short duration of opioid for acute pain, the CDC says 3 days. We'll see on the next slide what Virginia says. Evaluate the harms and benefits frequently. Consult a prescription monitoring program where available in the state. I noticed that one of you had mentioned that naturopaths in the state of Virginia cannot access that program, probably because in part for patient privacy issues, I guess. I'm a clinical pharmacist in a small hospital. I do not practice retail anymore. I have no access as an independent pharmacist. I could have access through my place of employment if I were dispensing to the public, but I don't have access. Do you practice in Pennsylvania?
No, I'm working on North.
Okay. Cool, I just didn't know. That was my original pharmacy license is in Pennsylvania. We didn't have a prescription drug monitoring database when I left there. We just had to file paper copies with the state every month. So I think that's changed since I left Pennsylvania, though. That was like 13 years ago, 15 years ago. So.
Still working on licensure there. It's
Okay.
like in the process of talking with the board about
Okay.
this.
Well, good luck.
We need it.
So for Virginia, opiate use acutely and non-cancer pain, less than 3 months. They want you to query the monitoring program if your therapy is going to be expected to last for more than 7 days. Assess the risks of abuse. So just a quick question out there. What do you think is the highest risk for abuse? I'll just throw a couple of factors out there. Female gender, previous injury, cigarette smoking, or herbal drug use, or herbal plant use. Cigarette smoking is actually one of the predictors. So people who have a history of being addicted to a substance are more likely to become addicted to a substance. So as I said, the CDC wants 3 days for acute pain. Virginia says 7 days for most acute, unless it's post-op, then up to 14 days. The number of pills depends upon the manufacturer's recommendations for use. Interestingly, also in Virginia, they're saying more than 15 morphine milligram equivalents per day. Record the reasons in the medical record. Well, why wouldn't you record the reasons in the medical record anyway? Is my question. Number two, their lower threshold for outside consult is 120 MMEs, whereas the CDC is 90. And then, of course, document appropriately as part of the guidelines. All right. So let's see. There's more geese in the long arm, right? That's why it's longer. Here we go. Okay, next, please. For chronic pain, it's not really that much different. It says urine drug screens. They're recommending now random urine drug screens to both detect the drug and metabolite, to look for diversion, as well as to pick up any unexpected metabolites. So Mr. Adams had spoken about diacetylmorphine, heroin. So if somebody shows up with diacetylmorphine in the urine, you know that it came from heroin. I did have a case when I was working at a retail pharmacy in Tennessee where some random person showed up off the street just crestfallen, and I'd never seen him before. He wasn't a patient of mine, so I just got fired from my job. I was like, dude, that's really too bad. What are we gonna say? And he's like, well, I take this prescription for hydrocodone from my physician, and they found hydromorphone in my urine, and they fired me. And I was like, well, that doesn't make any sense. How can more comes metabolite hydrocodone? The prescribing physician did not know that. The occupational health nurse did not know that. So, of course, working in a major retail pharmacy chain, I didn't have access to the internet, because why would you want your pharmacist to be able to look anything up? Good thing I'm old school before there was computers, right? I went home that night and printed off the pathway and told him to come back next week. He picked up and got his job back. But one of the things that just astounds me is how little prescribers sometimes know about the medications they prescribe. So I'll get off that backtrack. Anyway, next slide, steps 2 through 6. A couple of things, informed consent. Mr. Adams mentioned that as being part of the responsibilities and duties. Benefits, hey, your pain might feel a little bit better. Risks, well, you could get addicted and you might die. Let's use opiates. No, I'm sorry, I don't mean to be so facetious, because I do believe that the universe is honorable. The opium poppy papaver somniferum itself is not inherently evil. It's just that human beings being what we are. And I don't know if you guys, it was quite a few years ago now, they did a study in rats, and they found that if you put rats in a happy cage and give them access to opiates and cocaine, rats in a happy cage don't access opiates and cocaine. You put rats in a miserable cage and give them access to opiates and cocaine, and those rats do drugs. So if we're really looking at, right, responsibilities, duty, the war on opiates, maybe we ought to have a war on like the way we live unnaturally. I mean, I don't know, but
Or stress.
war on stress, yeah.
They consume it until they die.
Yeah,
I mean, it's not just the setting, but it's the extreme behavior as well.
right. And just as we humans do, people addictions to alcohol, opiates, cocaine, methamphetamine. When people are miserable, they do drugs until they die. So, and then here's the rest of the Virginia guidelines. I'm just going to go ahead and kind of skip. So our first line, pharmaceuticals for pain, just kind of summing up what I tried to say earlier. From the top down in the CNS, we can reduce that central sensitivity if we inhibit cyclooxygenase 2, or we inhibit COX-1 and 2 with NSAIDs, with our corticosteroids that are going to inhibit phospholipase A2. We can increase the inhibitory tone. That's where our opioids work to inhibit GABA's inhibition of the off pathway. Activation of our norepinephrine innervated alpha-2 receptors, our antidepressants, and our anticonvulsants work there. At the level of dorsal horn, we're looking at local anesthetics, given neuraxially, of course, because when you take them systemically, they're degraded pretty rapidly in the liver. Opioids, alpha-2 agonists, antidepressants, anticonvulsants, local anesthetics twice, why not? And we have an interesting calcium channel blocker that I'll briefly mention. Peripherally, we can look at reduction of sensitization through inhibition of our COX-1 and COX-2 with NSAIDs, or our COX-2 selective inhibitors, as well as steroids. And then we can suppress the signal using local anesthetics, calcium blockers, and anticonvulsants. One of the things I didn't think to include here, and perhaps should have after listening, well, I guess I couldn't since I sent it to you before I heard Mr. Adams, but the FDA just approved Epidiolex, which is a CBD-based product. It's a Schedule II prescribable drug. So it's only indicated for certain, like Dravet syndrome and Lennox-Gastaut in neonates, some severe convulsive disorders in children. But most of these things that I'm showing you here are going to be off-label. So just saying, Okay, we move on to the next one. We'll talk first about NSAIDs, COX inhibitors. Of course, we're all familiar with the pathway where we have a huge omega-6 intake in our diet, and we get those omega-6 metabolites in that SN2 position of the phospholipid membrane. We get a stress signal. Our inducible phospholipase A2, or calcium-dependent phospholipase A2, snips it off, releases arachidonic acid that's probably going to either undergo lipooxygenation to form the inflammatory leukotrienes, or cyclooxygenation to go to form prostaglandins and thromboxanes. We can go ahead to the next one. Of course, I know everybody in this room is intensely familiar with omega-3s, right? So I could probably not even talk about the anti-inflammatory properties of our omega-3s, when we have the right balance of omega-3 to omega-6 in the diet, when we have activation of phospholipase A2, we actually form anti-inflammatory products. I had a, and I think it was Dr. Lee who asked me if I like prescribed herbs. I guess it's kind of unethical. Here we go. I get to know my students very well. I'm, not part of that hierarchical, patriarchal thinking. I kind of figure we're all here together. We try to figure things out together. And I had a student who had broken his neck at one point in time, and the only reason he became a physician because the physician that he was referred to after it was in a motocross accident. He was in the emergency room, and the physician said, "You're never going to walk again." Now this is a redheaded Tennessean, stubborn. He's like, "You ain't telling me that I ain't walking again." So not only did he walk again, but he is now an osteopathic physician in his residency. At any rate, he was taking so much aspirin that his ears were ringing for the pain. He was worried about, well, first he was taking Tylenol, and I was like, dude, no, you can't take more than 4 grams of Tylenol a day. So he started taking aspirin. He ended up with esophagitis, GI bleeding. So finally he said, Babbles, that's my nickname for myself because I talk so much, Babbles. He's like, he did actually say Dr. Babbis, but I don't like that doctor thing. He said, is there anything else I can do? And I said, well, okay. Mary Beth talking to Jake, not professor talking to student here, okay? Close the door. Eat more fish. Eat more omega-3s. Decrease your omega-6. He did that and got actually substantial relief, and now he recommends that to his patients. So I'm just saying that you know better what you do than I know what you do, but together, we can work together to make our patients' lives better. Anyway, sorry, I don't mean to get, look what I did. Anyway, but I'm really proud of him anyway. We can move on. So prostaglandin effects, and I'm sorry, I'm a pharmacology professor, so this is on my pharmacology lecture. So basically, when I teach students both about the use of prostaglandins exogenously to do things like protect the stomach from the NSAIDs that you're prescribing, that's what we do in allopathy, is we give a drug that causes a side effect, and then we give a drug to treat the side effect of that drug. And then since the prostaglandin increases secretion motility in the gut, we have to give an antidiarrheal to treat the side effect of the drug that we're using to treat the side effect of the first drug. But at any rate, also from a different perspective is, you'll probably see many, many patients on NSAIDs. One of the side effects that we don't talk about is constipation. The prostaglandins increase water secretion and also improve motility of the gut. So now you got a patient on an NSAID and an opiate. So here's where we're seeing additive pharmacodynamic effects of drugs that are not to the patient's benefit. Okay, we can just move on. So we're all probably familiar with COX-1 being our constitutive housekeeping first step catalysis to make our protective lining for GI mucosa, to improve platelet stickiness through the formation of thromboxane A2, maintaining dilation of the 8th variant glomerular arteriole to keep renal perfusion going, especially in patients who may have compensated for like heart failure, renal arterial stenosis, etc. We also have our COX-2 that's considered to be more inducibly expressed after inflammation. So we talked earlier in a few slides about the NMDA receptor. Once you get enough stimulation that you're knocking the magnesium off of that NMDA receptor, calcium starts influxing, we start producing those inflammatory prostaglandin products. These prostanoids have a very short half-life. They function in an autocrine-paracrine function. So when our body is making the prostaglandins, it doesn't really need them. When we give these as drugs, they happen to affect most organs in the body. Okay, we can just move on. So here we have a case, 45-year-old, history of asthma, comes to the emergency department with crushing chest pain from an MI. He's given 4 chewable 81 aspirin. Shortly after taking the aspirin, he gets a severe asthmatic attack. He's never had an aspirin before. What's going on? It's actually an alteration law of mass action. We're changing the way arachidonic acid is metabolized. So now he's going to require a percutaneous coronary intervention for his MI. How long is that aspirin going to impact his platelet aggregation? Well, for the life of the platelet. Aspirin acetylates and irreversibly inhibits COX-1 coupled with thromboxane synthase to decrease the platelet activity. The platelet half-life is about 120 days, but really 7 days is generally enough for the body to make new platelets to overcome that inhibition. My third question is, why do COX-2 inhibitors promote thrombi? So if we go to the next slide, I have the answers. And click it one more time for the, there we go. So what we did is we put an X, so to speak, on our cyclooxygenase pathway. We inhibited our inflammatory arachidonic acid metabolites from going down the COX pathway, so they went down the LOX pathway, if you will, to form leukotrienes. Patients who have what I call scientifically twitchy lungs, which is the triad of allergies, asthma, and nasal polyps, can have anaphylactoid reactions from COX inhibition. And that's because their lungs are hyperreactive to leukotriene formation. So when you activate that phospholipase A2 and you generate arachidonic acid, and it cannot go down that COX pathway, it will go down the LOX pathway, make more leukotrienes, and you can have anaphylactoid reactions. So we also have this balance in our bodies between COX-1 and COX-2 products in certain constitutive fashion. So our platelets make thromboxane A2, which is a pretty powerful platelet activator. The healthy vascular endothelium makes prostacyclin, PGI2, which is anti-aggregatory and vasodilatory. They're normally in balance, but when we develop damage to our endothelium, excess reactive oxygen species, accumulation of excess cholesterol, if you believe that particular model, which I don't. But nonetheless, when we start having that damage to our vascular endothelium, we take away prostacyclin, leaving behind thromboxane A2. When we use, so our prostacyclin synthase is closely coupled with COX-2 in our vascular endothelium. So if you selectively inhibit COX-2, you're left with a product, thromboxane A2, that's pro-aggregatory. So this is why patients with coronary artery disease, high risk for cardiac events, probably should not be on a COX-2 blocker. So we can go to the next slide. So the other thing is it's complicated. Our prostaglandins, leukotrienes, and our lipoamides, including our endogenous cannabinoid system, are all interrelated. So arachidonic acid, besides going down the COX pathway, the LOX pathway, and then there's also another pathway that I didn't mention, could go down a pathway to form anandamide, which is our endogenous, one of our endogenous cannabinoids, or down the diacylglycerol lipase pathway to form 2-arachidonyl glycerol. So one of my theories that I postulate, and I've been trying to research this, and maybe some of you have encountered this somewhere before, is one of the things that I think might happen is when we block COX, we're actually getting some relief because we're increasing endogenous cannabinoid metabolites. I don't know. I haven't found that. I actually have found a couple references to that in preclinical type studies, but I've never found anything in human studies. Anyway. Yeah, okay. So if we're looking at NSAID inhibition of COX, the more COX-1 selective our inhibitor, the more likely we are to have GI damage. The more COX-2 selective, the greater our cardiovascular risk. All of the patients taking NSAIDs COX inhibitors are essentially at risk for acute renal failure because of changes in that afferent renal glomerular arteriolar tone. When we take away prostaglandins, it constricts, we can decrease perfusion to the kidney, cause kidney damage, can cause acute functional renal failure. We can also, especially as we get more COX-2 selective, see risk of major cardiac events. I have naproxen in green here, simply because it has about equal COX-1, COX-2, and in 2016, I believe they did a major meta-analysis and found that of all the NSAIDs, naproxen has the least risk of cardiovascular events. So that being that as it may, we have found that they are recommended for acute pain. The American Society of Anesthesiologists states that NSAIDs should be used for back pain. However, they're marginally effective for chronic pain. So that's the state of the evidence with our COX inhibitors. I love acetaminophen metabolism. I don't even know how Tylenol works. I'll be honest with you. I teach pharmacology. I don't know how this stuff works. I don't know that everybody has an opinion. The thing that I like to think about, well, the number one causative thing that makes patients need a liver transplant in the United States is Tylenol, and especially Tylenol combined with chronic ethanol consumption. Chronic ethanol consumption induces this normally minor pathway for acetaminophen metabolism, which is induction of CYP2E1. When acetaminophen is metabolized by CYP2E1, it forms N-acetylparabenzoquinonamine, NAPQI, which, if you know anything about chemistry, is an imine that binds to free sulfhydryl groups in the liver. We know where it's being made. When you get those that adduct forming with the proteins in the liver, you get an immune response that attacks the liver. You get hepatitis, drug-induced hepatitis. We can normally detoxify the NAPQI through a phase 2 reaction that requires glutathione. However, malnourished patients, as you well know, probably don't have glutathione. So here is one of the off-label uses for oral inhaled N-acetylcysteine. We give it orally to treat Tylenol poisoning. They recently came out with an intravenous form of an N-acetylcysteine that is approved for acetaminophen toxicity, but to my mind is, okay, we're bypassing first pass absorption when we give it IV. I've just always been really interested in how that works. But anyway, I know that N-acetylcysteine is used a lot in naturopathic medicine to help patients with that sluggish phase 2 metabolism. Yes, ma'am.
Is it possible, besides assisting with NAC, that you could possibly add sulfur groups to help with sulfuration or sulfation?
I am not familiar with it. I actually do recall a study that I read.
Attaching to those sulfur groups, I was just wondering
Yeah.
if you had, especially for people who are more caustic and stuff like that, if you could add in more sulfur groups to assist with.
Well, I mean, basically what we're going for is that free sulfhydryl group on the cysteine. I don't know anybody aware of any other way to get sulfhydryl groups in the liver. That was just one that I know. And I actually, I'm sorry, I just can't even recall, but I do recall reading another study that was looking at sulfhydryl pathways, but I'm sorry, I can't remember what the substrate was. Anyway, there you go. A medication that's been on the market before I was even born, and that was a long time ago, that only in 2015 did we figure out, hey, this stuff is bad, but you can still buy it, at whatever gas station you stop at, right? Anyway, we can move on. So botanical interaction with NSAIDs or acetaminophen. Piperine. Okay, here's where we go with our P-glycoprotein and our CYP inhibition. Piperine from black pepper probably enhancing the activity of most of our NSAIDs, including ibuprofen and diclofenac. But, so, hey, if we're not getting rid of the drug, it means the drug is accumulating, you're at higher risk for toxicity from the drug. So your monitoring would include, looking at things like blood pressure, risk of GI bleeding, CBC to detect a bleed. We can also see resveratrol increasing the Cmax in areas of the curve of diclofenac, which again, theoretically could decrease your dose of diclofenac, but I don't know why anybody would prescribe systemic diclofenac anymore. Aspirin and herbs that inhibit coagulation. A lot of controversy about this. I mean, does ginkgo biloba, I didn't include ginkgo biloba in this simply because it's not an herb that's normally intended for pain. And I was trying to focus on herbs for pain. But I'm starting to see now a lot of questions. Does ginkgo actually inhibit platelet function? There is a theory that ginkgo decreases activation of platelet activating factor, which is also part of that lipoamide acid pathway. I've seen patients bleed with high-dose aspirin and ginkgo, so anecdotally I'm saying, yep. But theoretically also coleus or Aesculus species, curcuma, the fungal cordyceps, Oenothera primrose, or Panax, cat's claw, clover, all potentially have this effect. Again, are you going to not do it? Well, I would, if something's working for pain, you want to do it. Heightened monitoring is actually the answer. Then there's also the concern of anything that inhibits COX with or angiotensin converting enzyme inhibiting herbs. So in allopathic medicine, we're always concerned about adding an NSAID to an ACE inhibitor or an ARB because our prostaglandins maintain afferent arteriolar dilation at the level of the glomerulus, and angiotensin 2 maintains constriction at the efferent arteriole to force filtration through the Bowman's capsule. Oops, sorry. So if we take away angiotensin 2, we take away prostaglandins, now we don't filter at the kidney. The blood flows straight through the afferent to the efferent, no filtration, you get acute functional renal failure. So angiotensin converting enzyme inhibiting herbs. Garlic, I think probably is part of the efficacy. Our Crataegus species, sorry, I spelled that wrong, Hawthorne, Ganoderma lucidum, Lespedeza capitata. Anybody use Lespedeza in their practice? It's a really cool invasive that is probably an activator of endothelial nitric oxide synthase. So, but it also, I'm sorry?
What's the common name? Is it just
I'm sorry, I can't think, I don't, it's an invasive, it's in Fabaceae family. Goats actually eat that plant to self-treat for an antihelminthic. So it is antihelminthic also. Anyway, I was just curious about that. Salvia multiriza also. So that could be, so what are you gonna monitor? Probably blood pressure, look for signs of pedal edema. Okay, we can move on. Looking at our anticonvulsants, here's where our two classes I have starred that have both on and off label use for pain. Our sodium channel inactivators, our carboxamide derivatives, carbamazepine, its relatives oxcarbazepine and esocarbazine, but also our alpha-2 delta subunit calcium channel inhibitors. This is a gabapentinoid, gabapentin, and pregabalin. Some of our not used as anti-epileptic drugs, things like ketamine that are NMDA receptor antagonists, actually can be used acutely for pain, in addition to their rapid treatment of depression. So I guess, so you're from California? They have ketamine clinics in California? Yeah, we don't do that here for some reason.
I have everything there.
Oh, okay, cool. But also we have our baclofen and our TRPV and cannabinoid receptors. So we could go ahead and go on. Just looking very briefly at our carboxamides, things like carbamazepine and congeners. Carbamazepine is the left-hand most molecular structure there. All three of these are relatives of tricyclic antidepressants. So there is a potential for serotonin syndrome. Our carbamazepine has a high risk of hepatotoxicity because that double bond in the molecule is highly reactive and can, again, react with sulfhydromoieties. In East Asian populations, these drugs have a very high risk of toxic epidermal necrolysis and or, on the less severe end of that spectrum, Stevens-Johnson syndrome. And there is a specific phenotype, the what is it, 5207, I can't see that. But we actually do now genetic testing before we use this drug in that population. And there's also a risk of aplastic anemia, and as with any serotoninergic drug, a risk of SIADH. Carbamazepine and congeners are powerful enzyme inducers. We can go ahead to the next slide. We also have our gabapentinoids, which were initially synthesized to be GABA agonists, but they probably aren't GABA agonists. What they do instead is they bind to that alpha-2 delta subunit of those voltage-gated calcium channels and prevent expression of those voltage-gated calcium channels to decrease the efflux of glutamate from those primary nociceptive neurons. It's probably more complicated than that. H.L. Mencken said, you know, for every problem there is an answer and a solution, neat, plausible, and wrong. Well, this might be one of those. A friend of mine, psychiatrist, calls these drugs the drugs in search of a disease. Hey, it doesn't work, give them a gabapentinoid. Let's see if it, yeah. So, that being said, in Virginia, Neurontin gabapentin is on the to watch list. In Tennessee, West Virginia, Kentucky, it's a scheduled substance. So this is not an FDA scheduled substance, but it is reported to the databases in all of those states. Pregabalin is a C5, so it is a federally Drug Enforcement Administration controlled substance. Side effects, anytime you're suppressing neuronal function to suppress seizures, you're going to look at sedation, ataxia, confusion, probably weight gain. We can go ahead and go on. So anti-epileptic drugs and neuropathic pain. Gabapentin, pregabalin, reasonably good evidence in neuropathic pains. Pregabalin, also good evidence for central neuropathic pain, fibromyalgia. There's really not much evidence for carbamazepine, even though traditionally it is the drug used for trigeminal neuralgia. There's no evidence for the other classes of anti-epileptic drugs, and maybe a slight statistical benefit from the sodium channel blocker lacosamide. We can go ahead. Interactions, sedating herbs, additive effects predictable. One of the things I find interesting is the herbals that you might prescribe that have pyrrolizidine alkaloids. Since carbamazepine is a powerful CYP inducer, your pyrazolidine alkaloids could actually probably form more rapidly those adducts for the veins, the hepatic veins, and cause the veno-occlusive disease more readily. Serotonin syndrome, and then gabapentin is interesting in that it is a drug that works in the CNS that carries a positive charge at physiologic pH. It actually undergoes active transport across the lumen of the gut as well as into the brain. So anything that's going to compete with uptake could diminish the effects of gabapentin. Also divalent cations. We could go move on. Antidepressants, we're really looking at our tricyclic antidepressants and our serotonin norepinephrine uptake inhibitors because what we're really looking at is norepinephrine. I had mentioned earlier that when the Raphe nucleus is stimulated to release serotonin, that can be inflammatory or anti-inflammatory depending upon the chemical below. Brain-derived neurotrophic factor is one of the things that, when present, enhances the likelihood of serotonin to cause an increase in nociception. Norepinephrine, as far as I know, and as far as I could find, is emphatically suppressive of nociception at the level of those interneurons in the dorsal horn of the spinal cord. So alpha-2 agonists at that point can reduce nociception. If you look at our evidence here, and I just cut this out of a psychiatry journal because I like pictures, you'll notice that our tricyclic antidepressants actually do have pretty strong evidence-based support. Our pure serotonin, selective serotonin reuptake inhibitors, modest to no. So really we're looking at drugs that decrease the reuptake of norepinephrine to reduce the effect in neuropathic pain. Okay, we can go to the next slide, which is about our SNRIs. Duloxetine, Cymbalta is indicated for fibromyalgia and other types of pain. Millicipred-Sevella for fibromyalgia. Side effects are my favorite name for venlafaxine, and it's Conjur-Vest venlafaxine are both off-label. Look at the side effects though. Hypertension, sexual dysfunction, suicidal ideation, and unmasking of mania. So,
how often do you really see that though? How often do you really see that for your folks that are on SNRIs?
The side effect profile?
Mm-hmm.
If I personally think, like, as far as the hypertension goes, you can take a patient who's predisposed for hypertension, add one of these, and cause hypertension. I'm guessing in a healthy 18-year-old, probably not a big deal, but it's not usually our healthy 18-year-olds that have fibromyalgia. So I think that it just enhances that underlying propensity. We can move on. I actually have not seen Sevella used in a long time. It just is indicated. Yeah. Yeah. Hey, let's give you this medication. Oh, look, now you're hypertensive. Let's give you another medication. Looking at our tricyclic antidepressants, we have tertiary amines and the secondary amines. The tertiary amines inhibit the reuptake of serotonin. The secondary amines, which are often the metabolites of the tertiary amines, inhibit the reuptake of norepinephrine. So our tertiaries like amitriptyline, Elidil, have a tendency to block both serotonin and norepinephrine uptake, where its active metabolite desipramine only inhibits the uptake of serotonin. Pretty effective for neuropathic pain, but is it because of the sodium channel blocking effect, which increases the risk of arrhythmias? Is it because of the antimuscarinic effect, a lot like scopolamine, for example, or Datura? Is it because of the antihistaminic effects, which we know can reduce pain? They're alpha-1 receptor blockers. They're also serotoninergic, but on another note, they do absorb UV radiation and can predispose your patient to a bad burn. Okay, evidence. Most demonstrate some efficacy in neuropathic pain. Our SNRIs can produce a reduction of up to 30% in fibromyalgia, but there's no evidence that they reduce pain by more than 50%, unlike some of our herbal products. A systematic review of pharm for low back pain found small improvements, but nothing very significant. So supplement antidepressant interaction. Here's where I wonder about the potential for tannins, a condensation reaction with the opiates as well as the antidepressants. Giving them concomitantly with high tannin content herbs could be an absorption problem. Most of our antidepressants are metabolized by CYP2D6. Our SSRIs in particular are fairly powerful inhibitors of 2D6. We have to think about venlafaxine prolonging the QT interval, especially if we're giving it with something else that might inhibit 2D6. Serotonin syndrome we previously mentioned. Caution with antimuscarinic herbs. Interestingly, Panax, ginseng, Garcinia cambogia, and Hypericum have all incidental reports of the unmasking of mania. So all of our antidepressants have this risk of switching a bipolar patient from depression to mania. There are case reports of some herbs doing the same thing. So it might be very careful to screen patients coming for treatment of depression for previous episodes of mania, and to watch those patients closely to make sure that you're not unmasking mania.
Question for lithium. A lot of us use low dose, like really low dose lithium as a supplement in our practices. I'm assuming that I'm not sure about like the risks there. They're usually talking about higher dose.
Yeah, I would say that the doses of lithium, those 3 to 6 to 12, therapeutic doses of lithium, prescription doses, there we go, that's where I'm ready for, 300 milligrams and above.
Yeah.
So anything way less than that, you're probably not.
Gonna have that risk, right?
Everything, it's really largely dose-dependent phenomenon. Opioids from papaver-somniferum. So technically, opiate refers to those native alkaloids from the plant. Opioid are the semi-synthetic derivatives. I have them listed here just because I can. This isn't even a comprehensive list because you notice that fentanyl is not on here. We can go ahead and move to the next slide. I've also, just FYI, divided them up to those opioids that have additional effects that limit their ceiling dose. And then on the next slide are Schedule 2s that don't have a ceiling dose. So theoretically, you can titrate up to the patient's tolerance to the medication. We could go ahead. One more, there we go. So effects. We have our mu opioid receptors, which is where our euphoria comes from, where activation of the mu opioid receptor at the level of the spinal column, from the periaqueductal gray down, disinhibits the locus coeruleus from releasing norepinephrine, increases potassium efflux causing hyperpolarization, decreases calcium channel activity to relieve pain. Also, our mu opioid receptors disinhibit dopamine release in the nucleus accumbens, in that ventral tegmental area, which is what makes them so exquisitely addicting. Inhibition, we can just go ahead, I already said that. So effects that are generally undesirable from our opioids: overdose, death by respiratory depression, allergies, pseudoallergy, they evoke histamine release, constipation, a side effect that tolerance does not develop to, respiratory depression, which is actually what causes death, nausea, vomiting, pinpoint pupils from most of them, except for meperidine, which actually activates the Westphal nucleus. opioid-induced hyperalgesia. And we had a discussion about the splice variants that are probably involved in each of our phenotypic expression of our mu opioid receptors, where some of us are actually, upon chronic exposure to opioids, going to develop a hyperalgesia. Addiction, we already mentioned that. So just definition-wise, dependence is, in pharmacologic terms, the physiological dependence, the body's downregulation of receptors upon repeated exposure to an agonist. So the physiologic signs of opiate withdrawal are actually dependence. That occurs because our bodies become tolerant to the presence of the exogenous substance. Addiction, on the other hand, is the continued abuse of the substance despite the negative sequelae from the abuse. So they are not synonymous. I think I just said that. So opiate naivete. When you read the literature and you talk about these strong opiates that should not be, like fentanyl patches, Duragesic patches, don't initiate them in an opiate naive individual. Anybody who's had at least a week at one of these doses is not considered opiate naive. In other words, the tolerance in the human body starts to occur after only 7 days at this level of dosing. We can go ahead. And I promise you, I know this is something you're all waiting for. Woo! Morphine milligram equivalents, here you go. So this is your conversion chart. This is to calculate the equivalency of a patient's current opioid regimen to translate it in terms of morphine. This is not a chart to be used when you're trying to convert one patient from one opiate to another, but rather to just speak in the same terms as far as morphine as the common denominator. We can go ahead. So withdrawal symptoms of a drug are generally the opposite of the drug effects itself. So since opiates treat pain, when you withdraw them, increase pain. Dysphoria, opiates cause constipation. When you take them away, you got diarrhea, cramping. Yawning, the opposite of respiratory depression. Mydriasis, the opposite of 10-point pupils. Pill erection, diaphoresis. It's not usually deadly, but I work in this critical access hospital in the emergency department. I have 3 physicians currently. We are in the center of the opioid crisis. We get patients come in on an opioid overdose. I have one physician who likes to bolus everybody with naloxone. The nurses hate him because you bolus a patient with the antagonist, they go through withdrawal, they're angry, they hurt, and they defecate everywhere. Okay, not pretty. I have another physician who will have a naloxone grip mix and just titrate it to keep the patient's respiratory rate adequate, monitor the patient, let them sleep it off. I have a third physician who will intubate everybody and just let them sleep it off. So the nurses hate the naloxone doc, the bolus doc. He's a bit sadistic. And maybe he just wants to make the nurses mad, I don't know. But it really, if you've ever seen naloxone given, it's not pretty. We can go ahead. Evidence. Okay, well there's about this much evidence for chronic opioid use. There's very limited evidence for chronic opioid use. There is a lot of evidence, however, that use of opioids causes significant side effects that lead to withdrawal therapy compared to placebo. Per the CDC, opioids should be initiated only when other alternatives haven't worked, when pain is affecting function or quality of life, and the potential benefits outweigh the potential harms. They continued only when you can document the relief. Oh, that's okay, go ahead. So here's our opiate metabolism. I like to tell my students the C's become M's. And I always act everything out because, otherwise life is really boring. So codeine becomes morphine, hydrocodone becomes hydromorphone, oxycodone becomes oxymorphone through the metabolism via CYP2D6. We also have the phase 2 conjugation pathways. It's interesting to note that morphine 6-glucuronide, which is catalyzed by uridine glucuronidol transferase 2B6, is more potent than morphine itself. The UGT1A3 forms morphine 3-glucuronide, which is a neurotoxin that can cause seizures. So when we have herbs that can disrupt these metabolic pathways, we put patients at risk of enhanced toxicity from the opiate itself, or perhaps enhanced toxicity from its metabolite. Next slide. So opioid interaction, additive effects, hyperforin inhibits 2D6. So here's where you could see diminished effect from codeine, which itself is relatively inactive. Also reduced effects from hydrocodone and oxycodone because you're not forming the active metabolites. Glycyrrhiza is going to induce UGT1A, which could reduce the effect of buprenorphine that almost solely undergoes metabolism through that phase 2 pathway. UGT2B7 is the deactivator of many of our opioids. So glycyrrhiza, cinnamon, and scutellaria may all inhibit that pathway. So just things to think about. I'm not saying don't put your patient who's on an opioid on licorice, but watch for signs of opiate accumulation. Next slide, please. Adjuvants, yay, we're almost done, right? Woo! Antispasmodics. Well, Dr. Guys, wish I was taking something before I got up here. I wish all my students that too. Antispasmodics, how do they work? It depends on which one you're talking about. Cyclobenzaprine, generic name for Flexeril, is actually essentially a tricyclic antidepressant. Bottom line. Carisoprodol soma is metabolized to the older agent meprobamate, which is known as Miltown or Equinil. That is a very powerful GABAergic that makes people die from overdose and causes seizures upon withdrawal. So it is now a scheduled substance. Baclofen is a GABA B agonist, actually has some antispasmodic activity. The rest of them, chlorzoxazone, metaxalone, methocarbamol, or phenadrine, probably just sedating. Tizanidine, Xanaflex is an alpha-2 agonist, so you're really looking at that norepinephrine inhibition of pain signaling. This is a cool one. This is from the marine snail Conus magnus. It's a new drug called Prialt. It is actually only administered neuraxially because it's degraded if you take it orally. And it was like really great for pain until we found out that, our brains need calcium channels to function too. And when you inhibit calcium channels in the CNS, you cause neuropsychiatric events. And you confuse the drug neuraxially, so you just gotta wait for it to wear off, sorry. Stinks to be you. So it's not widely used. Local anesthetics are gonna block our sodium, voltage-dependent sodium channels. If they accumulate, can cause arrhythmia and seizure. So not without potential harm. And I'm just going to go, where are we time-wise?
We are about 3:35. So.
Oh, I need to stop.
Yeah, we're
I need to stop. You need to, because I'll keep, no. I'm just going to, okay. Ketamine is something you might see very rarely as an NMDA receptor antagonist. And then cannabinoids. So this is really what I wanted to talk about, but now I'm out of time.
How about 5 more minutes? Does that work? Or we could cut our break short, 10 more minutes?
No, I'm just going to go through this very quickly. We've already talked about a lot of this. The coolest thing to me about the cannabinoid signaling pathways, especially when you're talking about that retrograde signaling, probably from the 2-arachidonyl glycerol, is that it reduces glutamate release. So we were talking earlier about how, cannabidiol really doesn't work for everybody's pain. I can see why. Neuropathic pain, maybe helping with diminished windup. Those are probably two of the places where cannabinoid agonists are probably going to be the most useful. Also, we're seeing an initial TRPV1 activation followed by desensitization. So we can see multiple levels of cannabinoid activity. So this is one where Sativex is a product available, generic name of Nabiximols in Canada, which is a pure cannabinoid extract, probably much more efficient at pain than the dronabinol that we use in the United States off-label brand name Marinol. So, I really think that this is an entourage effect from the plant itself that we're not going to see from any individual ingredient. We have our CB1 receptors, which are responsible for a lot of the euphoria, inhibition of the hippocampus that impairs short-term memory. Activity in the area posterior probably maybe helps. with the anti-nausea. However, there is an inverse relationship between orexin signaling, leptin signaling, cannabinoid signaling. So it's probably more complex than that. One of the cautions about use of any cannabinoid in patients is that it can unmask schizophrenia in susceptible populations. So there really is a pretty strong, the evidence of course is not causal because it's a retrospective evidence, but there seems to be a correlation between cannabinoid agonists and unmasking of previously undiagnosed schizophrenia. So that there does seem to be that risk. Our CB2 receptors, anti-inflammatory, inducing apoptosis, so there's a lot of research for anti-cancer, but there's also an anti-nociceptive effect from our CB2 receptors. And even more importantly, I'm thinking that some of these transient receptor potential modifications, the orphan G protein coupled receptors, NMDA receptor antagonism possibly, and modification of our peroxisome proliferator activated receptors, PPAR alphas and gammas, that this whole thing is what we need to look at, not one isolated compound. Oh, spoken not like a pharmacist who wants to sell drugs, right? We could just go ahead and skip the anatomy and go ahead. Oh, the one thing, give me back up just one slide, I'm sorry. So I had a slide earlier that talked about the formation of our lipoamide acids. Anandamide being 2-arachidonyl ethanolamide, is broken down by fatty acid amide hydrolase. Currently, they're in phase 3 studies. We have FAAH inhibitors. So there will soon be drugs that are targeting the breakdown of our endogenous cannabinoids. Okay. Please forgive me for going over, I'm sorry. And this was going to be part of my shout out to our microbiome people and the gut-brain connection. But really, without a healthy gut, all you're doing is increasing inflammation, contributing to that inflammatory soup. Interestingly, you can move to the next slide. Oh, sorry, one more. Here are all the potential conditions that cannabinoid research is undergoing as far as Parkinson's disease, Huntington's, Alzheimer's, multiple sclerosis, amyotrophic lateral sclerosis or Lou Gehrig's disease, post-stroke hypoxic ischemic injury, and then epilepsy. Potential, at least theoretical, pathways in which cannabinoids can work. The other thing we want to think about is that entourage effect. Russo, in his 2011 paper, looked at potential cannabinoid activity of all of these terpenoids in cannabis and other plants. I have a little smiley face by hops because that's Cumulus lupulus is one of my favorite herbs. But beta-caryophyllene is actually probably a quite strong agonist of our cannabinoid receptors. We can move on. Okay, here's just some other plants that may be useful. And then I think we're done. Cannabinoids for pain. So at least for MS central pain, we're seeing pretty strong evidence for cannabinoids in pain. Okay, and I think that takes us just to the summary slides that I promised you I wasn't going to read to you, but if you want to see where many of your herbal constituents work, they're in this particular table. I also have, on the next slide, evidence for non-cannabinoids in back pain if you care. And then finally, I have 3 slides that summarize. This is transport substrates, inhibitors, inducers, natural products in red. The same on the next slide for our CYP, isoenzymes, and then finally for our phase 2. Thank you for bearing with me. I really appreciate your patience. Oh, one of my favorites, Salvia julibriscens. I love Fabiaceae, it's one of my favorite plant families. My email address is there. I sincerely mean that we are a team. I am at your service. If I don't know the answer to your question, which I'll be honest with you, I probably won't, but I'm not afraid to look it up, right? I can research things for you. So thank you for your forbearance. I'm sorry I went over. And I'm sorry I broke her machine.
So, let's take a look. Ready?
Yo.
Sorry.
Okay, no, I'm not.
Okay, so we'll take about a 10-minute break. What time is it now, guys? Time?
I'm sorry.
It is 3:43.
3:43. So we'll start back at about 3:55. Is that right? Yeah. Good. All right.
I mean, that would be actually a whole topic is what actually gets published, all the research that they do versus what doesn't.
Yeah.
I mean, because if you understand, like I said,
Did it not?
I mean, it's probably a sound.
No, for the event, right?
They gave it a plus. There is.
I think it was there last week.
Oh, but it's not there now?
I personally think it has to be more after that.
It's all right.
So like people probably wasn't a similar cluster.
I just-
We probably don't actually intend it to go.
It didn't show up on the thing.
Some of the guidelines.
Microbiome designs for
I didn't know that NCPL study, it's like, this considered.
That's all right, we just need to hurry. Okay.
Oh,
So,
sorry.
it's okay.
Let me
Because I
put it
just
in there.
Don't mind screaming. I'll ask him how best to do that.
No, like it.
Yeah.
Thinking about it.
I don't know if you could just like.
Yeah,
This is.
yeah.
Now, what if they chain now?
Hi. So I have a question. So at lunchtime, I announced
Oh, yeah.
how would it be best to acknowledge our sponsors, taking sort of a snapshot at the end,
You can,
or having all their logos up?
well, we could do, well, why don't we try to do both? Let's do a thank you page embedded in your video too.
Okay, so you
And then if you have a graphic that you want to create or something with.
we can send it to you?
Yes.
Okay, all right. He's good with that.
No.
Yes.
They were on there also. I felt like specialty. Okay, because I feel like we need to officially acknowledge that.
Absolutely.
So I will say
Really trying to
something.
get all this started, so.
Right, otherwise they'll never do it, right? I mean, we already have 4 people calling sick, so that's good.
Well, hopefully there'll be some bonus in that with these videos we captured. That benefit.
Right.
You know,
Okay, so we can
Reinforce
wait
it.
when everybody's gone and just do that at the end.
We can, or when you're wrapping things up, we want to say thank you.
Okay,
We put it all in there.
okay, all right, I'll do that.
And if you want, you know, if you plan it just so that at the very end, not only could be embedded in the video, we could extract it later and make it a little
We
special.
have a two party
Just
system right
like
now.
30 seconds, 60 seconds.
So
Okay,
And then it's not really Facebook page.
thank you. Genius, yeah.
Well, while you're at it, if you think of anything else that you want to do, you can capture, you know, the clips if you like, and use them the same time.
Yeah, so you got it.
Okay.
So you got it.
All right,
Since we have everything set up.
all right, thank you.
Thank you.
So you feel.
It's on there now.
It's on there now?
Yeah, I don't know why.
How did you do that so quickly?
No, it's just, I don't know why, it was just gray out. It was just grayed out.
It just, oh, okay.
It was grayed out earlier. And now
Okay,
it's
great. So, microbiome. Then we've got Washington homeopathics. So they didn't actually sponsor the event, but they sent stuff, so I don't know how we.
Oh, who? How much?
Washington homeopathics.
Did they send the stuff?
They sent that.
Oh, I don't know. Oh. Huh.
Yeah, so they sent stuff to put in our bags and also, they didn't financially, they didn't.
Well,
they didn't.
Well, but they put the stuff in there, they put a lot of stuff in there.
No, it's just.
That's the attitude from a lot of time. I'll leave it today, but not for we're gonna write out.
Okay, thanks. All right.
So I'm really. Yeah.
I think just
Well, I said something.
yeah, and it's weird.
I'm in.
And you pull those into every day. That's true. Yeah, yeah. Right. No, I'm pretty sure that's not yeah. I mean, meat on whole and raw.
Oh, yeah?
I know.
I also have a scarf. I have.
Oh, they go.
I know, I I really wanted to talk. That's what causes that stimulating effect. Which bring pain. And then there's so you get a higher dose of
Can you do that? Is it like?
Yeah, I mean, patients with overdose has been, Not just they range the hotels are big.
I should say.
Because, you know, you're living parks and you don't have to feel like pathways, take that whatever pathway you have, and then, yes, increasingly getting integration, shifting things towards fast forward. So we don't have the cofactors in the average American diet. And therefore, we have too many carbs, this only is lack of So you have people, we all have different, polymorphism, yeah, there's probably a consistent that is something I know more people who started cars. I mean, I could know more people that one does not mean.
Although we left, we went to Hong Kong.
I mean, I can't.
So, and this is like my parents well, that's my grandfather.
I mean, I have come back to And everyone would miss.
So, Sarah, it's like one more step. As soon as the and all regular sponsors, and he said we could make it a itself so that we can send it through Facebook and everything, so that we can promote it and let everyone let them know.
Thank you.
What do I do?
I'm curious to your slide.
I think I'm still in hers. I just want to make sure.
So I just want to say, while you're working, everybody's really enjoying this.
Oh, good.
It's great.
I'm gonna talk about that in just a minute. I'm gonna tell you why I feel like it's been mouthful. I can just get through it, you don't have to. I just didn't. Oh, it's okay, maybe it reset okay.
So when it comes to before
That's right. Well, my thought is that I'm having it'll be one green background. It's 103 slides.
I have a back, I put everything on, Rob, just in case,
Yeah, I just never know. Thanks, Mary.
We're gonna get started back in just a few minutes here.
I really firmly
Make it look nice to see.
No, I'm just. I have yeah, about 700.
Yeah, it'll actually say if you didn't key, yada yada.
I don't like to get up. Hey.
There it is.
I'm contingency. Okay. I take my sleep back and it's on the ground.
Sorry about that.
If I have a second flash drive, I'll just send it around.
That has a line.
Yeah, I did. I remember asking for
How would they send out?
We were sent in a Dropbox. Okay, within the email.
Because I think you'll get, I think it's actually yeah, that's what you. But. Because that's.
Yeah, there could be. So, for some reason, just when I was making the consolidated PowerPoint.
Because I'm gonna be looking here, I wanna make sure that you can see me for the folks that are on the webinar. Can you see me? I'll probably be here to make sure that I can.
You get a view of yourself right there.
Oh, okay. I don't know what to see that actually.
Well, just to give you an idea of your placement.
Okay.
I'll turn it
Alright.
around because I'm going to monitor. but
Okay, awesome.
You can see.
Is this loud enough?
Yeah, it's picking up pretty well.
Okay, I'll make sure I project.
I mean, the first gentleman, people couldn't hear him, so
Yeah.
this mic is well. This is the one I'm doing.
Okay, all right, sounds good.
Yeah, please no. I mean, there's some they're the. But, yeah. Yeah.
Oh,
Because look, I put it up, and I just, oh, wait, no, you're back, so I get it now.
so Americans, maybe see how loud it is.
Still downloading.
It probably is. Sometimes it can be a smidge slow, like,
Because it happens when I go to my phone. Is there Wi-Fi there?
there should be. Ask Sarah. Or maybe Patricia.
Wi-Fi.
Oh, fascinating. It could be the wall.
There is Wi-Fi here. It's
I just found it.
CRC or something.
Yeah, I just found
access. You just have to agree to it over a web page. That you connect
I was trying to find a box to put on just so it wasn't SEO, but
Oh, the,
just something to like raise the images. It's okay.
I have a box.
Okay.
All in all, we're not in food court. Okay.
It's like over
Now, yeah, it's always easier.
Thank you.
That's great. Okay.
All right, we good? Okay, we're gonna get started, everyone.
So I'm just gonna go ahead and start because I know that our time is limited and I'm kind of at the end of the day, it's getting late. For those of you on the webinar, thanks for sticking around. For those of us that are here, by the time I'm done, it's gonna be dark outside, so I'm sorry. But I'll do my best to try to keep things alive and moving if possible. So first of all, I want to say to Sarah, thanks so much for putting this together. You've done a phenomenal job. I'm actually really, a number of times I'm lecturing and I don't really enjoy it as much as I'm enjoying it today. So this is like super fantastic and fun. And the previous speakers, I felt like they brought a lot to the table in management. So that's, and also just helping us as clinicians to do a better job. So I'm just going to dig right in. So disclosures, I don't have any. So we're going to skip on to the learning objectives today. So I'm hoping by the end of this that you can provide at least 2 specific pathophysiological changes for those that have PTSD, and also maybe pathognomonic. That would be really useful for you to identify the people who have PTSD, but maybe you've missed it before. I also want you to identify some groups of people who are at higher risk for PTSD. Third, to list at least 1 genetic variation. So if we're talking about like methylation changes and things like that, I want you to recognize that there are some things that can happen within biochemistry that affect people's ability to clear drugs, to be able to do even catecholamine degradation. And finally, I want you to come up with at least 3 therapies that you could do for your patients that do have PTSD, and that shouldn't be too difficult. So, basics and definitions. I know that you guys know what trauma is. I know that you've heard of PTSD, but just so that we are working from the same framework, what is trauma? you know that it's basically a distressing situation that happens, but as Jeffrey Alexander puts it, this is my favorite thing that my favorite things that he has to say is, it's a blow to the psyche that breaks through one's defenses so suddenly and with such brutal force that one cannot react to it effectively. So that makes a lot of sense. You've seen that in your patient population of people where they come in and maybe they're cachexic, maybe they can't sleep. There's a literal breakdown that has happened for them. So I'm going to just these definitions, I realize for those of you who are coding and those kinds of things, I've put some information in here. There's something that's called ASD, and basically this is acute stress disorder, and I want to differentiate that from PTSD a little bit. There can be some similar overlap as far as symptomology, but as far as the ICD-10, it is F43.0. And basically what happens is, even though it has similar characteristics of PTSD, which we will get to those in just a bit, it occurs within 1 month of the stressor. And so it lasts at least about 3 days, but no longer than a month. Whereas with PTSD, oftentimes what we will see is that it lasts beyond that month, and the symptoms are similar for ASD as far as symptomology. So that could include sleep disturbances, that could be having that fight and flight phenomenon. Just want you guys to know that. We do find that the most common events that lead to ASD are motor vehicle accidents, brain injury, rape, and also assault. So just to kind of keep that in mind, and of course that can be very similar for PTSD. There are some risk factors for these individuals, and we can see that it's witnessing a past trauma. Also, if there's a history of mental health illness, maybe even as far as that they have seen other types of traumas happen, and also being female. You will see the same thing also with PTSD. So the defining characteristics are basically that it's less than a month for ASD, whereas with PTSD it's over a month. So that's what this slide is right here. But the second determining characteristic around PTSD versus ASD is PTSD is defined as a mental health problem that occurs after a threat or a perceived threat. And I realize that our definition within medicine is maybe not perfect around this. We could really probably have maybe an ethical conversation about what really is PTSD and what should be part of that. But just for now, this is the way that they're defining things. So our characteristics of PTSD, you will not be surprised. You have seen this, you have read about this, you have seen this maybe in the literature, if you haven't seen it within your own patient population. But it's basically you're developing this alarm status. It's the fight and flight phenomenon, as we know. And it can come from an extreme traumatic stressor. Additionally, there's a threat of physical integrity or harm that maybe that they would not be safe. The other part of it is witnessing an event or learning about, and that's what we can see even around things like with 9/11 and that kind of thing that we might learn about later on. Or you learn about a family member who may have almost died, or you saw a car accident. Those are the kinds of things that can also characterize within this PTSD. So they put it as persistent mental and emotional stress occurring as a result of injury or severe psychological shock. I like to tell my patients sometimes, they don't understand why they're feeling the way that they are years later. And I say, well, it's like an earthquake, but you're still having shock waves. And we just have to help you have more resiliency around that. Maybe instead of building a building the way we used to, we have certain ways of building that building to where it can sustain those shock waves, which is what we've done in different countries after we've seen areas that have had significant catastrophes. So for PTSD, we're looking at ICD-10 of 43.1 versus the 43.0 with the ASD. And lifetime prevalence is about 8%. However, what you will find is that you're going to see it more in women than you're going to see it in men. So that overall prevalence is about 8%. So the criteria include being exposed and reliving the event. So they're trying to, and we're going to get to this, they're trying to reconcile it, but they keep reliving it. And so every time we go to relive something, we're trying to clear it. We are trying to reconcile it. So instead of the person shoving it away and being very scared, you have to, through many ways of therapy that you're using with patients, is that you have to let them recognize that this is also an opportunity of healing. This is why the body keeps going into relive it, is because it wants to reconcile. So they will then avoid, right? They don't want to relive it. So I'm gonna retreat and go someplace else. So they're gonna avoid things. They're gonna lose interest in things, hanging out with their friends, being with their family. The things that they used to do, they don't want to do anymore. There is a detachment that we see. There's a lot of negative thoughts that it was their fault. A lot of shame and guilt. So I have, and obviously because of where we're located, I have a fair amount of patients who were in 9/11. They moved south either from the Pentagon or from the Twin Towers. And so it's that survivor's guilt for some of them. And whether, I've actually talked to a couple of practitioners who have also helped patients with the tsunamis and also with Hurricane Katrina. And so this is that survivor's guilt that we can sometimes see. And then also they're going to experience somatic expression. And what I mean by that is they're going to have symptomology. They're going to have changes within interleukins. We're going to talk about that later. You're going to see changes around the way that they degrade their catecholamines, that kind of thing. So here's the cycle of PTSD. There's this event that happens. They're trying to relive it, but yet avoid it. So it's this push-pull. They don't know, and it can be a little bit different each time. It could be in a car, and then all of a sudden they're reliving that event. And then they have these symptoms, right? So then maybe shortness of breath, or maybe they're constipated, maybe they're having diarrhea, maybe they're having headaches, maybe they're having night terrors, those kinds of things. And then there's this detachment, shame, and guilt. So it's just this constant cycle. And the one thing that I want to point out about shame and guilt is that it shuts down the vagus nerve. So our vagal tone changes quite a bit when we have shame and guilt. Isn't that fascinating? So then you're affecting the vagal tone of the heart, the stomach, all these organs, even libido changes. So we're going to go in just a bit into more of the pathophysiology of what happens with PTSD. But I just want you to really, sometimes I pull this out and I have patients look at this because I want them to understand that what they're experiencing is not an anomaly. I want them to understand that this is the way that we're programmed and that we have to get out of this cycle. So anything that you can do to get them out of this cycle, even if it's going and buying a pink feather boa, even if it's like them painting something, if it's them painting their